So the title of our lecture is Assessment of Pain for Children and Adolescents. And the objectives are to provide a rationale for the need for chronic pediatric pain measures, describe and provide examples of self-report, parent report, and observational measures of pediatric pain and their relative strengths and weaknesses, to determine how we assess whether changes in pain are clinically significant, and to evaluate the evidence for the psychometric soundness of pediatric pain measures. So the rationale for measuring pain is to document the prevalence and severity of chronic pain conditions in pediatric patients, which has been historically underestimated, to evaluate pain as a disease-related symptom, such as with juvenile arthritis, and to monitor improvement in diseases using pain measures, to study predictors of pain, particularly ones that can be modified to treat pain, and to evaluate the outcome of pharmacological and non-pharmacological interventions for chronic pain. So the most common and gold standard for measuring pain is self-report measures, which can be used with children as young as 5 years of age and above. The most common is a rating of pain intensity using a visual analog scale, but also people assess the location, duration, and frequency of pain. It's not appropriate for younger or cognitively impaired children, and the stability of measures over time depends on the stability of the pain condition. So researchers are developing now electronic, or what are called e-health pain assessments, following measures that you're about to see are courtesy of Dr. Jennifer Stenson at Toronto Sick Children's, who's done a lot of work in this area. And the top part you see is the self-reported pain intensity for children 4 to 7 years of age using the FACES scale. And so you can see that on the far left is really symbolizing no pain, and on the far right more severe, or the severest pain that you can experience. And then there's the older child and adolescent report using a numerical pain rating scale. Also, they ask about the average pain intensity over the past 7 days, the frequency at which the patient has pain in the past 7 days, and then about how long does it usually last when they do have pain. The other part of this pain assessment is for the kids to indicate where they're having their pain, and they use a stylus to color in areas where they have pain. And as you can see, this is the sample computer report that's given to the provider summarizing in one particular patient where they had pain, the intensity of the pain, how much impact it had on their lives, if they had some fatigue in their mood. So lots of dimensions in addition to pain intensity. The pain measure that we've used the most in our research was developed by Dr. James Varney, and it's the PEDS Pediatric Pain Questionnaire, PEDS-QL. This particular version is for young children, 5 to 7 years of age, and the parents rate their children's pain. So here we ask the parents to describe their child's pain, to mark on a 100 millimeter line where their pain is, from not hurting to hurting a whole lot, and then the worst pain the child had in the past week, again marking on the line where they think their child's pain was. And then again there's a body outline where the parents can indicate by marking with 1, 2, 3, etc. the most painful to the least painful pain areas on the child's body. Observational measures of pain are useful for younger children, children with cognitive impairments, or when the child is too distressed to indicate their level of pain. Most of these have been used to measure acute pain during painful procedures such as injections. Behaviors frequently encoded include crying, grimacing, flailing, and screaming, which may really reflect distress and not necessarily pain, with neonates coding of facial expressions, which we'll show in a minute. have been shown to be reliably observed and associated with painful procedures. So this is the characteristic pain face that you see in neonates, with the brow bulging and forehead, the brows low and drawn together, the eyes squeezed shut, the cheeks raised, the nose broadened and bulging, and the mouth open and squarish. This is kind of the quintessential pain face associated with infants. Another measure of pain that's been used with children with juvenile arthritis is called the pain behavior observation method. In this method, the observer samples in 30-second intervals 6 different pain behaviors: guarding, bracing, active rubbing, rigidity, single flexing, and multiple flexing. The behaviors are scored as the child performs a standard sequence of maneuvers: 2 1-minute periods of sitting, 2 1-minute periods of standing, 2 1-minute periods of reclining, and 4 1-minute periods of walking. The range of scores is 0 to 20 for each maneuver, for a total pain score of 0 to 100. For this particular method, the inter-rater agreement has been very high, 90 to 95%. The kappa coefficients, which indicates the level of agreement taking in consideration chance findings, was also quite acceptable, 0.53 to 0.79. The validity was demonstrated by the total behavior pain behavior score, significantly correlated with functional disability and with visual analog scale ratings of pain for children and for parents. It's very useful for children who can't report on their own pain. It has some limited clinical utility because of the time and effort to conduct and code observations. Now, how do we know if there's been clinically significant changes in pain scores? Well, one way is to determine by expert consensus in the literature. The consensus seems to be that a 2-point change on a 0 to 10 pain rating scale is considered meaningful. Some people talk about a 50% reduction in pain scores from baseline to post-treatment. So, for example, in the headache literature, if you get a 50% reduction in the frequency of headaches from baseline to post-treatment, that's considered to be clinically significant. Another method is to focus on functional status and not pain measures, and answer the question, is the person now functioning well enough to meet their expectations for what they want to be able to do? So changes in functional status would indicate improvements. So the criteria for establishing evidence base for pain assessment measures. The Society of Pediatric Psychology had a task force looking at different measures, including pain measures. Well-established measures were those where at least 2 research teams have published information on the measure. There's sufficient information to evaluate the measure, and it has good psychometric properties. Measures considered approaching well-established if it's presented in at least 2 articles. There's sufficient detail available, and moderate or vague psychometrics are presented. An instrument is considered promising if there's been at least 1 peer-reviewed article, there's sufficient detail available, and moderate or vague psychometrics have been established. So the task force reviewed 17 measures. 5 were pain intensity self-reports, 4 were questionnaire and diaries, and 8 were observational measures. Of the 4 self-report measures, these were considered well-established, and 1 self-report measure was considered approaching well-established. 3 questionnaire diary methods were considered approaching well-established, and 1 was well-established. 6 observational measures were considered well-established, and 2 were considered approaching well-established. So the conclusions of that particular review by the panel was that we need to consider developmental and maturational levels in developing instruments, and not just reading levels. We need more measures for chronic pain in general. We need to develop measures for cognitively impaired children. We need to use pain measures, frequency, duration, and intensity to measure change as a result of interventions. And we have limited data on ethnic and racial differences, which calls for the need for more representative samples. And here are the references for the talk.